So our last speaker for this session is Emily Cherenack. So Emily is a fourth-year doctoral student in clinical psychology and a Duke Global Health Institute scholar, and she's mentored by Dr. Kathleen Sekema. So she is a graduate from Columbia University, and before coming to Duke, she conducted HIV research at a different university, at the New York University, Columbia, and the University of Miami. And research and clinical training focus on health psychology, global mental health, and the development and delivery of coping intervention to reduce the impact of stress on health. So she is currently working on a dissertation, and today she will be discussing depression and sexual trauma among adolescent girls and young women enrolled in HIV prevention research in Tanzania. Thank you.
Thank you. Great. So we know that adolescent girls and young women in sub-Saharan Africa are disproportionately impacted by HIV. And in Tanzania, where this research takes place, by the time girls are 18, almost 3% of them are infected with HIV, which is an increase from 0.6% among 15 to 17-year-olds. So clearly we need HIV prevention clinical trials that include adolescent girls, yet they are underrepresented in HIV prevention product trials. So one reason that so many adolescent girls are infected with HIV is because they face a number of interacting biopsychosocial risk factors. For example, depression and sexual trauma are both associated with HIV infection and sexual risk behavior. And it's possible that these same risk factors that increase girls' risk for HIV also impact their experiences and participation in HIV prevention clinical trials. However, before we can understand the impact of these factors on clinical trials, we have to first understand the pattern of depression symptoms, sexual risk behaviors, and sexual trauma in a sample of adolescent girls enrolled in an HIV prevention mock clinical trial in sub-Saharan Africa. And the implications for this could impact how we design clinical trials to be efficacious, acceptable, and feasible, and ethical to include adolescent girls. So the two main research questions for this analysis are, first, what is the pattern of depression symptoms in a sample of HIV-negative, sexually active adolescent girls and young women enrolled in a mock HIV prevention clinical trial in Tanzania? And two, is depression associated with sexual trauma or sexual risk in this sample? So this study took place in Dar es Salaam, a city in Tanzania, which is in East Africa. The data collected here are from the baseline portion of a mock clinical trial of microbicide use. So in this study, girls were given either placebo pills or a placebo lubricant gel meant to simulate microbicide use. But for this analysis, all data were baseline cross-sectional self-report data collected prior to participation in any clinical trial procedures. All items were delivered in Swahili and were translated, back-translated, and pre-tested with the adolescent girls, and research took place in an infectious disease clinic in Dar with adolescent-friendly services. So girls were recruited in a range of settings, and the final sample included 135 adolescent girls and young women between the ages of 15 and 21 years old with a mean age of 18. The average age of first sex was 16, and per inclusion criteria, all girls were HIV negative, not currently pregnant, although they could have been pregnant in the past, and had been sexually active in the past 3 months. So we received ethical approval in both the United States and in Tanzania for the protection of human subjects, and mental health professionals were available for referrals as needed. To measure depression, we use the PHQ-9. So the PHQ-9 is a brief screener for depression symptom severity that is commonly used in clinical practice to diagnose major depression and track symptoms over time. So using a cutoff of 10 shows good specificity and sensitivity in predicting major depression, and it's been previously used with adolescents and adults in East Africa and is shown to be reliable and valid in these settings. In clinical practice in the United States, scores of 10 or above can warrant watchful waiting or support when symptoms last less than 2 months, but longer than 2 months could warrant psychotherapy and or antidepressant treatment. So from top to bottom, on the PHQ-9, the items represent anhedonia, which is little interest or pleasure in doing things, low mood, problems with sleep, fatigue, problems with appetite, poor self-worth, problems with concentration, psychomotor symptoms, and thoughts of suicide or of self-harm. For sexual trauma history, we asked girls about their first sexual experience and their last or most recent sexual experience. And they could have, their responses were collapsed into two categories. The first was coerced or forced, and that included both persuaded and coerced sex and forced and raped sex. And the second option was willing or wanted sex. For sexual risk behavior, we asked self-report, so for unprotected sex, contraceptive use, reproductive tract infections, and age of first sex partner. And for demographics, we collected data on age, education, relationship status, religion, marriage status, pregnancy history, and orphan status. First, I conducted descriptive statistics to understand the pattern of responses on the PHQ-9, and then I conducted a series of binary logistic regressions where the outcome could have been none to mild depression or moderate severe depression, which was 10 or more. And any demographic items of significance and anything that was significant in the bivariate analyses was placed together in a single multivariate model logistic regression. So looking at the findings, first with depression, the mean PHQ-9 score was 7.87, which falls into the realm of mild depression. 73% had none to mild depression, but of these, 10% endorsed thoughts of suicide and self-harm. 27% did have moderate to severe depression, and of these, 35% endorsed thoughts of suicide and self-harm. And between both categories overall, 17% endorsed suicide or self-harm. The most commonly endorsed items were little interest or pleasure or doing things and feeling down, depressed, and hopeless, which were both endorsed by 78% of participants. And of note, these two items comprise what is called the PHQ-2, which is an ultra-brief screener for depression. In looking at 5 different categories of depression severity on the PHQ-9, you can see that the majority of participants, so 55%, had mild depression, and then moderate depression, which 22% of participants had. Here you can see the mean score on individual PHQ-9 items, and just as a reminder, 0 is not at all, and 3 is nearly every day. The highest scoring item was anhedonia, followed by sleep and fatigue. And sleep and fatigue are commonly the highest reported items on the PHQ-9, and the lowest reported item down at the bottom is suicidality. In terms of sexual trauma, we found that 42% reported coerced or forced first sex, and that included 31% who reported persuaded or coerced sex, and 11% who reported physically forced or raped sex. And at last sex, 7% reported coerced or forced first sex. And now looking at the logistic regression, so in the univariate models, last sex, forced or coerced, and the sexual risk behaviors were not significant in the univariate analyses, so they were not added to the final multivariate model. But in this model, when controlling for the demographics of age, education, and relationship status, we found that first sex, coerced, and forced predicts depression severity, such that those with coerced or forced first sex had 3.16 times the likelihood of having moderate to severe depression. And when you look here at the spread of participants, so on the left-hand side, we have all the participants who had no to mild depression, and of those participants, 18% reported forced or coerced first sex, and on the right, you have those with moderate to severe depression, and 40% of those participants reported forced or coerced first sex. So in thinking what this means, it's clear that depression and sexual trauma are pretty common and interacting factors among a sample of girls enrolled in a HIV prevention mock clinical trial in sub-Saharan Africa. So this highlights the need for trauma-informed clinical trials, and what this means is creating a safe and empowering environment for people who have experienced trauma. So that includes education of study staff, being able to recognize the symptoms of traumatic stress, screening for traumatic experiences, and providing referrals for further care as needed. Clinical trials also need referrals, procedures, and safety planning for depression and suicidality if they're going to ask that 9th question on suicidal thoughts. In addition, because trauma was so high, we really do need research on the implication of sexual trauma on women-controlled HIV prevention technologies such as vaginally delivered microbicides. In addition, shortened screeners such as the PHQ-2 or even the PHQ-8, which doesn't ask about suicidality, may be really good at predicting major depression, but they're still going to miss suicidality and self-harm. And that's because suicidality and self-harm are not always prompted by major depression. So one interesting limitation of this study is that we only had moderate reliability for the PHQ-9, so Cronbach's alpha was 0.64, which is lower than in some other studies. And this could be in part from cultural presentation of depression symptom clusters. So for example, the PHQ-9 has emotional symptoms of depression, somatic or physical symptoms of depression, and cognitive symptoms of depression. And it's possible in this particular sample, they just don't hang together all that well. You could also see there's a big difference between the mean score for anhedonia versus suicidality, so that could explain some of the moderate reliability as well. It was translated and back-translated and pre-tested with the girls, so we don't think it's a translation issue or a problem with them understanding. But to really understand what's going on, it would be interesting to conduct factor analyses using this measure in this sample, longitudinal delivery over time to see where the variation is really coming from, and also consider using the PHQ-A, which is designed for adolescents, although it's really minimal differences, like they just replace the word newspaper with schoolwork and little things like that. But overall, we do need research on if and how depression and trauma is impacting clinical trial participation, adherence to clinical trial products and instructions, and clinical outcomes, as we do know that mental health and stress impacts biophysiological processes. So it's important to know whether we should include mental health and trauma as mediators or moderators or covariates, or address them directly in interventions to improve intervention outcomes. So I want to thank Joy Noel Baumgartner and the rest of the study team and the institutions here and in Tanzania, and of course the study participants. And are there any questions?
Is it known from previous trials how depression and trauma affect adherence in particular?
Yes, so they negatively impact adherence. So especially, what we know most of is from those who are HIV positive, it affects medication adherence. So I think we need more research on how it would impact something like PrEP, and certainly more research on something like a vaginal microbicide. So there's not a ton of literature on that, and that seems especially prone to be impacted by something like sexual trauma.
For the causes of depression, you put a lot of emphasis of sexual trauma, but in Africa, there's also other aspect that if you look at, in particular, when you show the trajectory between the 1617 to the 1924, that is where girls usually are not very much supported in progressing in their education. And there are a lot of studies that have been done that show that actually lack of education and all of that has a real impact on the incidence of infection among the girls. So are all those other social aspects of moving from 17 to 19 that impact their role in the African society going to be considered in terms of triggering depression?
Yeah, so we did look at education, so years in school, and it trended on significance in predicting depression symptom severity. But I do think it's going to be part of a larger syndemic where there's things like poverty, education, sexual assault risk, early pregnancy, all of that is going to impact depression. And I know that's something that a lot of us are researching further in our own work. So to be decided.
Any other question? Thanks, Emily.
Thank you.